Okay, good morning everyone. So let's start the class. Today, uh, the first half of the class is about fracture healing. I've already started this topic from the last class, so let's continue it. Okay, I like to do a bit of revision in the beginning. Now, there is one important point regarding fracture healing. It is not like healing of any other connective tissue because most of those connective tissue they heal by fibrous tissue or scar formation, but fracture or the bone heals by forming bone itself. It doesn't heal by scar formation. It heals by forming the mineralized mesenchymal tissue or bone itself. So this is a very important point regarding fracture healing. Now, a fracture begins to heal soon after it occurs, and it occurs through a continuous series of stages, which we discussed in the last class. Those stages are stage of hematoma, stage of granulation tissue formation, stage of callus. Okay, in some of the book, the granulation tissue is also written as pre-callus. Stage of callus, stage of remodeling, and stage of modeling. So these are the different stages. So let's elaborate on them. Now see here. Okay, let's revise a bit, then we move further. So regarding the stage of hematoma, see here, when the fracture occurs, because of the injury to the blood vessels, there is leakage of the blood in that area. That blood will elevate the periosteum. You can clearly see it will elevate the periosteum, and this is called hematoma. So the approximation time or approximate time for hematoma is less than 7 days. And in this condition, there is sensitization of precursor cell occur. Now you may be wondering, what are these precursor cell? These precursor cell will later on differentiate into different type of cells, okay, which forms the callus. So they originate mainly from the periosteum. The periosteum is the outermost covering of the bone. So from there, most of these precursor cells they originate. And some of the textbook even mention they originate from the bone marrow. Okay, if bone marrow is still there, and sometimes they even originate from very small blood vessels or from the blood cells itself. Now the second stage is a stage of granulation tissue. It occurs up to 2 to 3 weeks. In this stage, the proliferation and differentiation of these precursor cells, okay, or daughter cells into the blood vessel, fibroblast and osteoblast. This osteoblast is the bone forming cell. You already know that. The mature form of osteoblast is called osteocyte. These osteoblasts are very rich in alkaline phosphatase enzyme. Please remember these words which I am mentioning here, because these are very important from the exam point of view. In the stage of granulation tissue, the fracture is still mobile. Means if we move that part, okay, then we still can feel fracture is not stable, it is still moving. The third stage is stage of callus formation. So it takes up to 12 weeks. Okay, and in this condition or stage, I should say, there is mineralization of granulation tissue occur. Now, mineralization means the calcium and phosphorus, okay, goes and deposit there. The callus become radiologically visible now. If we take the X-ray, we can see a callus is formed in between the fracture bone. That means, okay, the bone is healing properly. Now, stage of remodeling. In this condition, the lamellar bone formation occur. Now, probably in the beginning, this callus is mainly woven bone. Later on, it is replaced by a lamellar bone. And stage of modeling means there is some ongoing, modification occurring in the fractured area, so that after a few years, that fracture site is indistinguishable from the parent bone. Means we cannot even identify, is that the real fracture site after a few years. So these are the different stages of fracture healing, okay, and it is described by Frost in 1989. Okay, now see here, another slide is telling us, okay, about the microscopic changes which are occurring in the fracture site. Now see here, stage 1 is hematoma formation, similar. Stage 2, there is acute inflammation going on. Acute inflammation is all about neutrophil migration there. Stage 3 is macrophage activity. Now these neutrophils are replaced by monocyte or macrophage. After that, there is a granulation tissue. Okay, we already talked about it. Granulation tissue is also known as here procallus. Now in this condition, the neovascularization or new blood vessel formation and fibrous tissue formation occurs. Woven bone will form now. Woven bone. Okay, this is the stage of callus formation. Woven bone, and a cartilage also form at that site, and this cartilage will later on change into the proper bone. Now, lamellar bone is a stronger type of bone. Remember in the last class we talked about the structure of the bone. There are two important types, woven bone and lamellar bone. In woven bone, the cells and everything are same, but they are haphazardly arranged. In lamellar bone, they are very compactly arranged. And remodeling and modeling are other stages. Okay, now have a look here. Look at this picture carefully. So again, the same type of concept has been explained. This is a stage of hematoma. Okay, and here there are formation of the new blood vessels. Okay, formation of callus, and ultimately, okay, the fracture is healed, isn't it? And these are the same concept or explanation in the other way. Here, so hematoma, okay, callus or pre-callus, you can say, proper callus or bony callus, and remodeling. These are the main stages of fracture repair or healing. This callus is also known as pre-callus. This is the proper callus. Okay, so according to a different book, a little bit slight difference would be there, but concept is same. Now, all of you, please, okay, pay attention on the screen. And do not, open your screen and go somewhere else. Many of the students do that, I know, but don't do that, okay, for these, few hours, because this is very, very important for you. Now, in day 1, I can clearly see the fracture site here. See here, okay, there is a fracture line which can be seen. So nobody is mistaken there. Now, okay, let me accept some of the students first. Fine. Now, on day 4, okay, on day 4, you can see this change slightly, okay. There is a bit of sclerotic changes going on here, and no callus is seen here, no callus. In day 7, see here, okay, now I can see this granulation tissue or pre-callus stage. Callus is still do not form here, it takes time. In 2 weeks time, see there, now I can see a proper type of callus. And then see here, after 6 months, okay, where is the fracture site? I have to see it very carefully. Yes, I can see the fracture site because the proper modeling occurs after many years. It takes few years for the proper modeling, means it is almost indistinguishable from the parent bone, but till now that stage has not been reached. So still I can see this is the fracture site because there is a bit of sclerotic change. But if I take the X-ray after 2 to 3 years, probably I cannot even see this area. Now, see here, okay. So this is a good, slide which is telling us this is a stage of bony callus. Okay, this is a spongy bone in the beginning, or woven bone we can say. Later on, it is replaced by lamellar bone or compact bone. This is a radiological appearance of the fracture repair. See this, I can clearly see the callus here, okay? Callus. isn't it? This is radius bone, okay, and this is ulna, radius and ulna. Now, this is the external callus, which is swollen, and this external callus or swollen area would be disappearing within few years, okay, and the smooth and straight line would be there after few years. That is called modeling of the bone. Now, this class is important, and this question is very, very important from the exam point of view. So all those stages are explained again in a slightly in detailed way. Okay, so let's go through them now. The first stage is a stage of hematoma. It may last up to 7 days. Okay, there are torn blood vessels or ruptured blood vessel which leads to hemorrhage. You can clearly see here in the picture. This is the hematoma stage. So what this hematoma will do now, it will elevate the periosteum. Okay, this is elevation of the periosteum. Now this area is swollen, definitely very painful and inflamed area. The fracture is very painful site. Okay, the person has excruciating pain at the fracture area, and they cannot use that part of the body. Severe pain would be there. Now this is another picture, okay, which is showing the same thing. The periosteum is torn. Okay, so let me use the pointer and explain to you. So there is a torn periosteum. Okay, this is the fracture line. You can see there is a collection of the blood. There is a bit of necrotic bone marrow. Okay, on the other side the periosteum is intact though. Okay, and up to a certain distance there is a dead bone. They all will be removed by the macrophages, and they will be replaced by the new bone. They will be replaced by the new bone. Now the second stage is a stage of granulation tissue. Most of the point I've already explained to you. Have a look here again. This stage lasts for about 2 to 3 weeks, and in this stage the sensitized precursor cell, which are also known as daughter cell. Now, once again, from where this daughter cell originate? Yes, this is the question for you.
Marrow.
It
It
is
is
and bone marrow.
bone marrow.
Okay, good.
From the bone marrow it comes.
Exactly. Very good. Okay,
Peristome and bone marrow.
very good. So just now I explained that to you. So the important site is periosteum. Another site may be bone marrow. Okay, periosteum and bone marrow. These are the important areas, and sometimes they are even, differentiated from the blood itself, the hematoma itself. So these daughter cells, they differentiate and organize to provide blood vessel, fibroblast, and osteoblast. All of these are very essential in the formation of granulation tissue in the beginning, and later on that granulation tissue will form callus. Now see here. So this granulation tissue is not a new word for you actually. From the class of pathology, you have studied about that. The wound healing topic was, I'm sure, was studied in pathology, and granulation tissue is a collection of inflammatory cells, okay, fibroblast, and some of the tissue which is synthesized there. So the combination is called granulation tissue. Later on, the same granulation tissue will develop into scar, okay, if we talk about skin and some other area. But in the bone, the granulation tissue will, okay, develop into bone itself. It will develop into bone itself, and that is called callus. In the beginning, it is woven bone. Later on, it will convert into lamellar bone. Now see here, okay, so a little bit detail still written here. The granulation tissue stage eventually gives a soft tissue anchorage to the fracture without any structural rigidity. The fracture site is still mobile at this phase or stage, still movable or mobile. This is the important point. This concept we already talked. Now another stage is a stage of callus. Now this stage lasts for about 4 to 12 weeks. 4 to 12 weeks. 12 weeks means 3 months. Okay, 3 months. And most of the childhood fracture, they get healed by 3 months of time. Now in this stage, the granulation tissue differentiate further and create osteoblast. Now these osteoblasts are bone forming cell. So these osteoblasts, they lay down an intercellular matrix. So they lay down the intercellular matrix. So let me explain this because this is important point for you. So intercellular matrix which soon becomes impregnated with calcium salt. What they are telling us, in the beginning there is formation of the osteon. Okay, is a component of the bone. Okay, it's an important part or component of the bone which later on is mineralized by calcium and phosphate salt. Now this, in the beginning we call it Ubon bone. So many times I've explained this point to you, Ubon bone, because it is haphazardly arranged in the beginning. Now let's move on. Okay, wait. Okay, now see here. Now let's go further about this stage of callus. The callus is the first sign of union which is visible on X-ray, and it usually takes 3 weeks after the fracture. Now look at this X-ray very carefully. Okay, this orthopedics, one of the very important part of orthopedics is the X-ray and that X-ray reading. So you have to develop that habit. Now I can clearly see slight elevation here on both sides, and the fracture line is also not that properly visible like in the beginning. So this fracture is definitely healing. This is called callus. This is called callus. The formation of this breeze or callus of woven bone imparts good strength to the fracture. So fracture is no more mobile now. Okay, it is no more mobile at this phase or stage. This callus formation is slower in adult than in children, and in cortical bone than in cancellous bone. Now in adult it takes longer time for the fracture to heal than in children. Okay, always remember this point. Later on in the later half of this class we'll talk about that. And there are two important types of bone, cortical and cancellous bone. So in cortical bone, okay, it is slower than in cancellous bone. Cancellous bone is a spongy type of bone. A lot of woven bone would be there. Okay, so it is easier for that bone to heal faster than the compact or the cortical bone. So these are the important points. Here also you can see the callus. This is callus. Now let's move further. Now see this, the callus formation theory. Okay, already talked about. Actually this is just a repetition of the same thing which we have talked. From where these cells originate, from where they come there, what is the origin? So these osteoprogenitor cell present in all endosteal and subperiosteal surface which gives rise to callus. Already talked about. See there, subperiosteal means periosteum is the source, endosteal means bone marrow side is the source. So again the same thing is coming. Okay, so slowly they differentiate into osteoblast, and then that osteoblast is, okay, making the new bone which is called woven bone. Now let's move on. We are going to the other stages. Stages of remodeling, which is also known as stage of consolidation. This consolidation was the older term which used to be there, but these days we like the term remodeling. Now in this stage the woven bone is replaced by mature bone which is called lamellar bone. Already know. This process of change is multicellular unit based, whereby a pocket of callus is replaced by a pocket of lamellar bone. Okay, very easy to understand. So again they are saying the one bone which is there at the stage of the callus formation is slowly replaced by the stronger bone or organized bone called lamellar bone, and it is a slow process. It takes anything from 1 to 4 years. Okay, so this is ongoing process. See this? The callus of spongy bone, okay, is there. Now the last or the final phase or stage of fracture healing is a stage of modeling. Okay, the stage of modeling. So what happens at this stage? Let's talk about it. In this stage, the bone is gradually strengthened. The bone is gradually strengthened, and it is very difficult to identify what is the fracture site. If I check, okay, X-ray of that particular fracture site after many years, this is what happens. Now, the sapling of this cortex occurs at the endosteal and periosteal surface. The endosteal surface is the inner one, periosteal surface is the outer one. Okay, so this is what happens, and ultimately, one very important point you can remember here is the medullary cavity is obliterated in case of earlier stages of fracture healing, but after this stage of modeling, the medullary cavity is, you know, it will be just like a prior bone or the normal bone. There is maintenance of the medullary cavity. So when we see that, we think the stage of modeling is almost done or complete. Now, what is the major stimulus to this process? It comes from local bone strain like weight bearing and contraction of the muscles. Now, this is a normal phenomena because after the fracture become immobile, after about 3 to 4 months, the person starts to use that part of the body. If it is in the lower limb, the person starts to walk. If it is in the upper limb, the person starts to use the muscle group for different activity. So that is the stimulus for the stage of modeling. This stage is more visible in children with angulated fracture. It can be seen very easily there. Okay, and it occurs to a very limited extent in fracture in adult. So this is called stage of modeling. Now, so let's talk a little bit about healing of cancellous bone. Now, till now we are talking about healing of compact or cortical bone. So all these stages occur typically in the cortical or compact bone. Now, what is the difference of healing in cancellous bone? See here, the healing of fractured cancellous bone follows a different pattern. Now, in this condition, the bone is of uniform spongy texture and has no medullary cavity, so that there is a large area of contact between the trabeculae. Now, in fractures healing, there is one very important principle. The surface of contact is very, very important to understand. If it is larger or more, okay, the fracture will heal in a better way. Okay, if the area or surface of the contact is less, for example, if the upper end of the bone and lower end of the bone are not in contact with each other, okay, there is a very less chance of fracture to be healed. Now let's come back. In case of compact bone, okay, uh, they, because of the small diameter of the bone, because the small diameter of the bone, the contact surface may be already a bit less than in a spongy bone. Now I will give you few examples here. Now in case of long bone, which is compact bone and which are spongy bone? Yes, answer that to me. In long bone,
Head of the humerus.
Epiphysis is the compact bone, sir, and epiphysis, the end of the bone, is cancellous bone, sir.
very good. Yes. Okay. That's a perfect answer. So in long bone, always remember the diaphysis or the shaft or the main part of the bone is always a compact bone, and the ends, the upper end and the lower end, which are formed from epiphysis, they are cancellous bone or spongy bone. So if fracture occurs towards the end of the bone, there is a easier healing of that fracture because of the cancellous nature. But if fracture occurs at the shaft, probably it takes a bit of longer time for that fracture to be healed. That's what we are talking right now. The union can occur directly between the bony trabeculae because of the large surface contact, okay, and subsequent to stage of hematoma and stage of granulation tissue formation. Now mature osteoblast, they lay down woven bone in the intercellular matrix and the two fragment unite. So because it is already having woven bone there, cancellous bones are all about woven bone, okay, so that woven bone again forms when the fracture heals. So the process is always quicker, okay, always easier than in the compact bone. Now let's move on. There are some other concepts we need to know here. What do you mean by primary and secondary bone healing? Now let's talk about it. Primary and secondary bone healing. Now primary bone or fracture healing occurs where fracture hematoma has been disturbed, as in fractures treated operatively. The bone heals directly without callus formation, and it is therefore difficult to evaluate the union on X-ray. So let me explain this in an easier way. Now sometimes what happens, okay, we believe, or the orthopedic surgeon believe, this fracture needs open reduction and internal fixation. So let me write that term for you here. Okay, it is called ORIF in the short form, ORIF, ORIF. Now the full form of this ORIF is open reduction and internal fixation. Now, what do you mean by that? We admit the patient in the hospital, we take the patient to the operation theater, okay, we clean that area, we give anesthesia, everything, and then we give incision to that area. We open that area and see exactly, okay, what is happening there. We reduce, okay, and then we apply some plate there, some screws, probably sometimes some rod or nail. This is called internal fixation. This is an excellent way of fracture healing. But when we do that, most of the time the hematoma which is formed there, okay, will be lost now because we are giving incision there. We are creating that area into open wound, okay. So we don't need to worry that, because we are going to apply some rod, some plate, some screws, so that those two ends of the bone will be in tight contact with each other. This type of healing is called primary fracture healing. So see here, this is a very good X-ray. This is a fracture site. Let me show you here. See here, this is the fracture site which all of you can see. Okay, now I cannot see any callus here. Where is the callus? Nothing, no callus. Why there is no callus? Because there was no hematoma. The hematoma was disturbed. The hematoma was drained probably when you give the incision. So this is the internal fixation. See this plate and the screws. So this is an excellent way of treating the fracture. Okay, the exact alignment is there. Okay, now what is the another one now? See here. Now the second way of fracture healing is the secondary fracture healing. That's what we are talking till now. Secondary fracture healing, and it occurs in fracture where fracture hematoma is not disturbed, okay, as in the cases which are treated non-operatively. Now this non-operative type of treatment is the conservative treatment. That what we do most of the time if it is possible. isn't it? This is called POP treatment. Let me write that term for you. Okay, orthopedic or this fracture management is all about that. POP. Now, do you know what is the full form of POP?
Plaster of Paris.
Very good. Okay, very good. Plaster of Paris. Plaster of Paris. Now, this is also known as plaster in the layman term. So whenever we get fracture, we go to the orthopedic surgeon and they put a plaster there. This is called conservative management of the fracture. We don't open the fracture site. Okay, so this is called fracture healing by secondary way. Now, there is healing with callus formation, and it can be evaluated very well on the X-ray. We can see the callus on the X-ray. Now have a look here. See this area. See, we can see elevation here. We can see elevation here. We can see a little bit of osteosclerotic area at the fracture site. That means this fracture is healing, and this is called callus. It also occurs in fracture which are operated without disturbing the fracture hematoma, as in fractures fixed with relative stability, like in comminuted fracture. So I already explained this to you. Why in primary fracture healing there is no callus? Because probably the hematoma which was collected there was drained. Okay, it is no more there, and from the hematoma everything is going to form later on. But even if we treat the fracture by surgical way, but if we do not disturb the hematoma, then still, okay, we can see the callus. But that doesn't happen commonly, okay, because of the incision, most of the time the hematoma is disturbed or it is lost or drained. Now one small question to you: what is comminuted fracture? We already talked about this. Yes, comminuted.
It's a multiple piece fragment at
More
the
than two
fracture
fra-
site.
more than two fracture side. More than two small fragments are present in this fracture.
Very good. So see there, you can answer on your own way, but the meaning should be there. Very good. All the students are answering perfectly. More than two fracture pieces would be there, or multiple pieces of fractures would be there at the site. This is called comminuted fracture. And remember one thing, though it looks very bad in the beginning, this comminuted fracture heals quite comfortably than other fracture, like a transverse fracture, for example, because of the larger contact area there. So this is important point. Now let's move on. Let's talk about what is the rule of bone healing. What is the rule of bone healing? Now a lot of MCQ questions can be asked, or these are important knowledge for you in the clinical practice. The lower limb fracture takes twice time than upper limb fracture to heal. Twice more time than upper limb fracture to heal. Okay, so this is what sometimes our patient tells us, doctor, till when my fracture gets healed? So you can roughly answer like that. Now, fracture in elderly takes twice more time to heal than fracture in children or young age, because in elderly the process of mineralization, the process of osteon formation is late. Okay, it takes time. Transverse fracture takes longer time to heal than spiral or oblique or comminuted fracture. Okay, you can add there. Okay, transverse fracture takes longer time to heal than other. It's all about the area of the contact between the fracture site. No fracture unites before 3 weeks. So 3 weeks is the minimum duration for the healing of the fracture. Now there is a common consensus or rule in children. Upper limb fracture takes 3 weeks time to heal, and lower limbs fracture takes 6 weeks time to heal. See here, lower limb fracture takes double time than the upper limb fracture, 3 weeks to 6 weeks. But in adult, upper limb fracture takes 6 weeks to heal, and lower limb fracture takes almost 12 weeks to heal. 12 weeks. In 1 month, there are 4 weeks. So 3 months, okay, time taken for the healing of lower limb fracture. So this is a longer duration, okay, but it also depends on so many factors there. So this is the normal thing which we are talking. If that patient is having some bone disease there, for example, local disease or generalized disease, okay, so many other factors are responsible for the fracture healing, which we are going to talk now. Now see here, what are those factors which affect fracture healing? This is a very important question from this topic, okay, and very routinely asked in the exam as well. So please pay attention. We'll continue after the break also. The first thing is age of the patient. Now, just now we talked fracture unites faster in children, okay, faster in children than in adult. In younger children, the callus is often visible on X-ray as early as 2 weeks after the fracture, and okay, it takes half time lesser than in adults. That is the rule. Failure of union is uncommon in fractures of children. It unites very easily. Regarding the types of the bone, the flat and cancellous bones unite faster than cortical or tubular bone. Okay. The pattern of the fracture. Okay. Regarding the pattern of the fracture, the spiral fracture unite faster than the oblique fracture, which in turn unite faster than the transverse fracture. It is all about the contact surface. Okay, what is the surface area of the contact surface between the fracture end? Now, regarding this comminuted fracture, a little bit of explanation is necessary here. Now, I just now told you before the break that comminuted fracture heals way easier or better than other type of fracture, but we need to fulfill some criteria there. Number one, it should be okay a closed type of fracture. The compound or open type of comminuted fracture doesn't heal properly because of the loss of blood there. Probably the fracture hematoma doesn't stay there. And second one, the bone has to be normal. If a comminuted fracture occurs in okay disease type of bone like osteoporotic bone or some other type of bony disease, then definitely the healing will take time. Any type of fracture will not heal in time in disease type of bone. Okay, so that's why it is written like this. Comminuted fractures are usually result of severe trauma or mostly they occur in osteoporotic bone. That's why they heal slower. But if they occur in normal and healthy bone, and if it is a closed type of fracture, then they heal faster than other. Now, another important point is disturbed pathoanatomy. Let me explain what do we mean by this. Following a fracture, the changes may occur at the fracture site and it may hinder the normal healing process. These are soft tissue interposition and ischemic fracture end. Now let's analyze them one after other. In between the fracture end, if there is a piece of muscle which is lying, okay, if there are some nerves, for example, some other soft tissue, okay, fracture is not going to heal because it is preventing the callus from bridging the fragment. So we need to be careful about this. Soft tissue interposition will not allow the fracture to heal in time. Very easy concept. Another one is a ischemic fracture end. If we lose the blood supply, okay, on the fracture site, then it is a big problem because that fracture is not going to heal in time. One of the very important example regarding this concept is fracture of scaphoid bone. Now see here, let me underline this for you. Fracture of scaphoid bone. Now where is scaphoid bone present? Where?
Carpal bones. Carpal.
Very
Carpal
good.
bone. Carpal bone.
Very good. So all the students are saying it's a carpal bone. Excellent. This is an example of carpal bone. It is present on our wrist area. Wrist area, okay? Scaphoid. It is present towards the base of the thumb. Base of the thumb. And this fracture is very difficult to diagnose also in the beginning. There is probably no fracture line in the beginning, and after a few days, or sometimes even after 1 week or 10 days, the fracture line will appear. So only thing here is pain. When we press that scaphoid bone, there will be tenderness, and this is the one of the important point for the diagnosis of the scaphoid fracture. Now this scaphoid bone, okay, uh, the it is divided into upper end and lower end, or upper part and lower part, and this blood supply to this part will be disturbed in case of fracture, so it doesn't heal in time. It takes longer time to heal. Another point or factor in fracture healing is a type of reduction. Now reduction means, okay, reduction means, let's explain in another way. There is a fracture, okay, which is displaced, okay, displaced. Now displacement of the fracture means the two fracture end, the upper end and the lower end, okay, they are moving away from each other. Especially when we talk about displacement, we always see the lower part of the bone and where it is moving from the upper part. This is the way we tell the different terms there. Okay, now let's come back to the slide. If the type of reduction is good one, means the two ends of the bone are in good opposition to each other, there will be faster union. At least half the fracture surface should be in contact for optimal union in adult. So even if you cannot bring two fragment in contact completely, even half of the fracture surface is in contact with each other, then it will heal nicely. In children, a fracture may unite even if bones are only side to side in contact. This is called bayonet reduction. So in children, everything is easier and faster. So even if they are on side to side, okay, contact, then they can heal. This is called bayonet reduction. This is one of the important term. So let me underline that for you. Okay. Now another important point is immobilization. Now it is not necessary to immobilize all fractures. For example, fracture rib, fracture scapula, fracture of the skull bone, okay, we don't need to reduce them, we don't need to immobilize them, because these all are flat bone, and flat bones are usually they don't take participation in the movement that often. So just they heal after certain duration, okay, they need just some time to heal, and during that time if pain occurs, we give painkiller, that's it. So they are very easy fracture to heal. But if the fracture occurs in the bone of our upper limb and the lower limb, we constantly use those body part, okay, so if we constantly moving those fracture end, they are not going to heal. So these fractures need strict immobilization, okay, they need strict immobilization. You can take the example of all the fracture of the upper and lower limb for that. So fracture of the neck of femur is a perfect example, and it needs strict immobilization, then it can heal. But fracture of the neck of the femur is one of the very difficult fracture to heal in time. We'll talk about this extensively when we reach that particular topic. Let's move on. Now open fracture, they of course go into delayed union and even non-union. Now why open fracture do not heal in time, or very difficult to heal in time, or they don't heal at all? Why is that?
Because there is no contact, there is
The open
more
environment
contact area.
hematoma.
Chance of infection.
There is no contact
Now so many
between the ends.
answers, very good, so many answers are coming, and Let me tell you, all of those are correct. There are so many reasons you can give. Very good, excellent. You are thinking in a very good direction. Number one, open fracture means it is in contact with the external environment. I can see the fracture site from the outside. There is loss of skin. There is probably loss of soft tissue, and there is loss of hematoma also. So there is very less, chance of collection of blood there. So that is one important factor for decrease chance of healing or delayed healing. First thing. Second, there is high chance of infection. Okay, there is high chance of contamination and infection, and whenever there occurs infection, there is very poor type of fracture healing. Any type of wound doesn't heal in time in case of infection. And another point is also true. Okay, it is very badly displaced. One of the fracture bone may be poking outside from that wound area, and another may be going into another direction. So there is very poor contact between the fracture end. So all these reasons are important. Another one, compression at the fracture site. Now see here, compression enhances the rate of union in cancellous bone, and even in cortical bone, compression at the fracture site enhances rigidity of fixation and possibly results in primary bone healing. And this is the very, very important principle for open reduction and internal fixation. This is the surgical treatment of the fracture. So what they do, they'll open the area, okay, put a very nice plate there and screws. The two ends of the bones are very tightly compressed with each other. Excellent type of fracture union. Okay, so remember one point, if we compress that fracture site, if both ends of the fracture are in contact with each other, then there is a faster type of healing. Now all of you please focus on this slide. Focus on your screen now. See there. So in X-ray, this is how we see the fracture healing. Okay, in X-ray, this is how we see. See here, slightly elevated area on the side. This is the callus. This is the callus formation. See here. Okay, so we know this fracture is healing. Okay, we know that. Now let's summarize this topic. Okay, by this slide. These are the factors which affect bone healing. So in the exam, if this question is asked, you can answer like this and explain a little bit. That would be enough. So these are the factors which enhance the bone healing. Youth, younger the patient, better the healing. Younger the patient, better the healing. In children, okay, the fracture healing is the best. Early immobilization of fracture fragment, excellent. This is the excellent point. This is the principle of fracture treatment actually. Even after application of plaster of Paris or POP, the bone, the site will be immobilized, and we ask that patient, don't move your fracture area because it is important for the fracture healing. But for flat type of bone, okay, flat type of bone, we don't need any immobilization because they are not used in the mobilization process. That's the important point. Bone fragments are in contact with each other, it always enhances the healing. Adequate blood supply is very, very essential for the good type of bone healing. If ischemia, the bone doesn't heal in time. Proper nutrition is important one. In malnourished child or adult, the bone healing doesn't occur in time. And adequate hormones like growth hormone, thyroxine, and calcitonin, all of these are important for the bone healing. Remember the effect of calcitonin on the bone. What calcitonin will do in the bone?
Reduce the level of calcium in the blood.
Bone.
Okay.
Reduce the level of calcium in the blood.
Okay. So good. That is one way of answering. Or you can also say it takes calcium, okay, from the blood to the bone, isn't it? It takes or deposit calcium from the blood to the bone. That's how it decreases calcium in the blood. Exactly opposite of parathyroid hormone. And this is important, for the healing or for the synthesis of bone. Now let's go to the another side. What are the factors which inhibit the factor of bone healing? Now already talks about the age. Okay, let's not repeat it again. Extensive local soft tissue trauma. This will inhibit the bone healing. This is known as compound or open fracture. Sometimes even there is a soft tissue present in between the fracture site. If bone is lost due to the severity of the fracture, then it will hamper the bone healing. Again, I can give the example of compound and comminuted type of fracture. Compound and comminuted. Now there are multiple pieces of fractures there, and if the wound is open there, and if one small piece of the bone is lost from there, now definitely and naturally it will take a long time to heal or do not heal at all until and unless we do some bone graft. Inadequate immobilization, already talked about. Infection, you already know this principle. Whenever there is infection occurs at the fracture site, it will never heal. And avascular necrosis, lack of blood supply. Okay, scaphoid fracture is a good example, and fracture neck of the femur is another good example, because the head of the femur, it receives blood supply through the neck or via the neck. So if fracture neck of the femur occur, those blood vessels will be damaged, so head will be necrosed. So these are the very important point in fracture factors which affect bone or fracture healing.